Right, so today also we discuss a patient with shortness of breath and අද නම් මතකද ඉල්ල ගන්න. කියවෙයිද දන්නේ අර කිවරනකොට. ඔයගොල්ලෝ එන්න බලන්න කට් කරලා නම් එන්න එපා. ඊ වැඩ ඉවරලා ඉන්න. නැත්තම් කියයි මම කිව්වා කියලා කැරොල් බලන්න ඉන්න කියලා. බල ඒ වගේ වුණේ. So this patient also has shortness of breath, but we want to discuss something about him.
I am presenting G.A. Chandasari, a 61-year-old retired CTV driver from Katana, who was a diagnosed patient of hypertension for 20 years on antihypertensive drugs, diabetic for 20 years, currently on insulin, a CKD patient for 15 years, recently started dialysis, awaiting for renal transplantation, presented with shortness of breath for 11 days and dry cough for 15 days duration.
Shortness of breath for 11 days and cough for
Dry cough for 15 days duration.
15 days.
Since 2015, he was on nitrofurantoin prophylaxis for recurrent UTI up to 2017. In early 2017, he got acute onset.
Oh, මේ යාල් දේවි දුම්රිය අල්ලන්න යන්න එපා. එමි කියපා. 2000 මොකද 2015?
Since 2015, he was on nitrofurantoin prophylaxis for recurrent UTI.
Okay.
Up to 2017.
Okay.
In early 2017, he got acute onset progressive shortness of breath on exertion. It was not a diurnal variation pattern of shortness of breath, and it was not relieved by rest. So he was admitted to NHSL for 11 days and discharged with drugs. After 6 months of first episode, he got second episode of shortness of breath at rest. The pattern was same as the first episode. He was admitted to NHSL and referred to chest clinic Borella.
Wait. Now, is there anything else you'd like to tell us about these two episodes? For example, first thing that I would like to know is, in between these episodes, was the patient fine or was there some persistent shortness of breath?
During 6 months of period, walking distance on level clock has been reduced by 10%.
10%. ඒ කොහමද කියලා
I asked him.
meters ගන්න. Okay.
And
So there has been some exertional short. So what you're telling me is that since 2017 so 6 months he had shortness of breath, but these are but worsening episodes. So it's something like that you mean. Okay.
and he has to go rid of riding bicycle during this period.
Right. Anything else you would like to tell us about this shortness of breath apart from diurnality and අනම්මනම් ඒ වගේ දේවල් එක්ක?
Any orthopnea?
Yeah, so we don't use those words, no? So he does not have, or the shortness of breath does not, is not worse in the lying down position, or he does not awake in the middle of the night with episodes of shortness of breath. You can use orthopnea P and in the summary, but not in the history, right? Okay. Then did he have any other respiratory or cardiac symptoms during this time? So that's also important to mention. No respiratory or cardiac symptoms. Hari. Okay. He didn't have, I just write orthopnea PND there. Ankle edema.
No, I didn't.
Right. So we stop there for a moment and discuss now. Hari, you can turn your chair and sit. Right. So the way you started presentation was good. You gave a good background disease. So there is some improvement now. So that's good. Background history was clearly mentioned, right? This, did you look at the ticket before taking the history? No. Okay. So this is something that you might include in retrospect. I'll come to that, why that is so. But this is the predominant problem, isn't it? 2017, when was 2017 when? මොන මාසෙද? Right. So somewhere in 2017, Tamai's problems have started. He says it was rather acute onset, but it was progressing, and there are two distinct episodes in this patient's history, but in between episodes also patient had a worsening shortness of breath, and now also he comes with the similar sort of presentation. Similar presentation. That's a pattern or the character of this patient. This is the story that we are seeing in this patient. Clear? Right. Now, day before we started a discussion on shortness of breath, right? Talked about causes of chronic progressive shortness of breath, right? Now I want you to take 2 minutes and write down the differential diagnosis for this patient from the information that you know so far. I will try to argue for and against, which you are going to do quite a lot in the first few weeks of your appointment. What's important is symptom analysis. That's what we want to do. That's the foundation of medicine, and most of the long cases are marked on those principles. So what are the differential diagnoses you would want to mention in this patient? We discussed about this, right? Shortness of breath. So just remind me the chronic cause of chronic shortness of breath. And then we discussed this about 2 days ago. Heart failure, pulmonary hypertension, the cardiac causes. Respiratory causes we are talking about asthma, COPD and interstitial lung disease. Both obstructive and restrictive airways disease included, right? And restrictive, I told that there are certain odd etiologies like extra thoracic restriction, right? Then we also talked about renal disease and anemia as possible causes of shortness of breath. Renal disease would cause shortness of breath in many ways. One would be anemia, the other one would be due to fluid overload, and sometimes, rarely, cardiac involvement, cardiouremic cardiomyopathy. Now write the differential diagnosis for this patient. Taking into account the three now, he has had 3 important episodes of presentation, but in between also he has been having some worsening shortness of breath. So that's a basic pattern that Dilux has described to us very nicely. Right? At the exam also don't present that fast, because the examiner will be in a sort of a messy situation trying to understand your pace. Hari? So this is another case of shortness of breath. So we will be doing several cases because we want to highlight various types of presentation, various disease conditions. We have done 3 symptoms so far: PUO, shortness of breath and jaundice. So we are going quite well. Take into account the background history and what Dilux has told us so far. What is the differential diagnosis? Smoking, Tibbal? Smoker for 20 years. No? How many pack years? X. Kavada navatala 20 years ago. We don't know how much he has smoked. Ne? Pack years. Right. Yeah. What do you think? Hasida? I never. Okay, so we write what you say on the side. COPD. I am writing in the order that you tell. Huh? Yes. CKD causing shortness of breath. CKD for how many years you say? 15 years. 15 years. Interstitial lung disease. Kasun says interstitial lung disease. Anemia. Anything else that anybody wrote? Okay, fine. This is a friendly discussion. Talk, that's the importance of discussing. Yes, Shamal, yours. Piribase, Lakmin, you want to say something? No? You are happy with this? Right. Hasita, why did you say COPD? Okay. Long time ago. Right. Anybody? Okay, that's it. So Hasita said COPD. Okay, she has argued for it. It's smoker, but there is smoking, even though he's ex-smoker, there is history of smoking. There are intermittent episodes and progression in between. Okay. Anybody who does not agree with Hasita? That COPD should be a cause for his. Okay, so there is a large lag period between the smoking and the onset of the disease if it was COPD. So what these are we are arguing against now. So for, you are very correct, against. And now what we are trying to do is we are trying to prioritize things. And the more for versus against, you will come at the top now. Okay, right. Anything else that is against a diagnosis of COPD? Erang? Ini mata ini tiga. Oh. Sand in the yellow. Yes? Cough is against COPD. Cough initially. He has cough now, but not initially. Okay? Absence of cough, but that's not a very strong thing, isn't it? Right? Another important thing I told you when we were talking about COPD is exacerbations are usually infective exacerbations in COPD where they have fever, sputum, purulent sputum and cough and respiratory symptoms. Anything else? Nipunla dennek kenada nipunnawi nipunui dennawa nipunada කොහමද ඒ දෙන්න වෙන් කරගන්නේ කොට උස හරි උස නිපුණ කියන්න බෑනේ What is the prominent shortness of breath that you get in COPD? It's a wheeze, no? Wheeze and tightness of breath. That was not a wheeze that he had here. Okay. That's against. Right. So these factors we would against. Hari. CKD. Vikashana. Huh? Vichakshan. Yes. Why did you say CKD? Okay, you say that CKD can be complicated with anemia and that can cause shortness of breath. Okay, so that's a rational argument. This patient has a history of CKD and CKD can cause anemia and that can cause shortness of breath. CKD can cause fluid overload or heart disease, cause shortness of breath. What is against CKD causing shortness of breath? Against? Fawn Umali, would you like to tell us something? What are the symptoms? Okay, so there are no uremic symptoms. Anything else about this shortness of breath character? Yes. CKD shortness of breath, when it's due to fluid overload or cardiac involvement, the patient will have pulmonary edema, isn't it? So then the patient should have the symptoms of pulmonary edema. right? So what are symptoms of pulmonary edema? Patient should have orthopnea, paroxysmal nocturnal dyspnea, and also other features of fluid overload like body swelling, right? And renal failure, some you mentioned uremia, some uremic symptoms. Uremic symptoms are things like nausea, vomiting, metallic taste, hiccups, right? So even though this patient has a 15-year of CKD, very likely to be requiring dialysis also to this point, right? But fluid overload, if that was causing his shortness of breath, you would expect to find orthopnea, paroxysmal nocturnal dyspnea, ankle edema, which you have told us was not there. So that's unusual, isn't it? Right? That's a bit unusual. And even if it was involved in the heart, you would expect the same symptoms to be there, right? Right, now you have learned the pathophysiology also of these two symptoms, so you need to argue now, right? So in the exam also will ask you, why don't you think the CKD is causing his shortness of breath? So then you will tell, yes, the patient has 15 years of CKD, true, but I would have expected the patient to have some orthopnea or paroxysmal nocturnal dyspnea, because I know the mechanism is related to pulmonary edema, fluid overload or heart failure, right? So that's the way you argue, right? Also, there are no features of uremia, as somebody mentioned. At this time he should have, the patient have a shortness of breath due to renal failure, he should have uremia. Of course the shortness of breath might be due to anemia, but he does not have any anemic symptoms either, isn't it? Right. So anemic symptoms like malaise, lethargy, those sort of symptoms also he does not have. So the argument that CKD is causing shortness of breath is now becoming less likely. There are a lot of againsts for that, right? Now similarly, if you had said heart failure also, because now he has a lot of risk factors for heart failure, hypertension, diabetes, everything, CKD, but heart failure also is less likely in this patient because he does not have body swelling, he does not have orthopnea and PND and other features of pulmonary edema. So that would also be less likely in this patient. Right. So you understand the argument now going on? Okay. Right. Now Kasun mentioned interstitial lung disease. Why did you think of interstitial lung disease? Isn't it a very rare condition? Okay, shortness of breath is progressively worsening. There are some exacerbations, but it is gradually progressing, which I told you, interstitial lung disease, it's an exertional shortness of breath. With time it comes at rest also, but it slowly progresses. Anything else? Yeah, then this boy mentioned that there was some dry cough also now coming up, right? Dry cough. So that's the way it presents. Interstitial lung disease, that's the way it presents. So if I were you, I would put that at the top of my list, right? This I would put there. I am not saying the others are wrong, but they are less likely, right? So the most likely thing in this, given the nature of this patient's shortness of breath, would be something like interstitial lung disease. Right. So I think I've done a sort of a class on interstitial lung disease also for you before we came here. But interstitial lung disease, typical presentation is this. I might have also told you at that point that if you are always thinking of interstitial lung disease, try to find the cause for it in the history, right? So now tell me the causes in general without focusing on this patient. What are the causes of interstitial lung disease? Ayesha? Okay, drugs are rare. Anything commoner than that? Okay, occupational ILDs, yes. Especially with things like asbestos exposure, yes. Or silica exposure. Yeah, okay, cotton, hypersensitivity pneumonitis, you have heard of chronic hypersensitive pneumonitis. Read a little bit about it. It's a postgraduate topic, but small account of that. So occupational lung disease, asbestosis, silicosis, then Berylliosis, about of berylliosis, beryllium exposure. That occurs Sri Lanka wala. So in the sort of, in Kandy it's quite common because there are pahang handana they get exposed to beryllium. Tamba, copper industry, they mix beryllium to the compound, so they can get that. So beryllium, silica, asbestos exposure. Or this spectrum of disease called chronic hypersensitive pneumonitis, where there are various antigens in stuff like cotton or hay and piduru, which causes an inflammatory reaction in your lung, right? That's called hypersensitive pneumonitis. So has he been exposed to any of those, did you ask? What is his job? What was his job?
CTB driver.
He was a former CTB driver, okay. He has been exposed to a lot of environmental pollutants probably, but not anything specific. Okay, good. Yes, so occupational ILDs are very common, very important. Right, so chronic hypersensitive pneumonitis, and I think I forgot this Kurulvatikarana pigeon, that also chronic hypersensitive pneumonitis, that also can cause chronic hypersensitivity. Why I think I told this to you, there was a patient about 2 or 3 years ago with that lot of lovebirds, right? So chronic hypersensitive pneumonitis is that. Right, okay. So apart from occupational lung diseases, what are the other causes? Connective tissue diseases. Yes, that's a very common cause as well. Connective tissue diseases. Remember some of them? මොනවද? SLE වල එච්චරම එන්නේ නැහැ. Rheumatoid arthritis. And other famous one is systemic sclerosis. Scleroderma, systemic sclerosis. So other famous cause of ILD. Okay. Then, before coming to drugs, there is another disease which is a granulomatous disease that presents with interstitial lung disease. That again is sort of a postgraduate disease, but anybody knows what that is? Sarcoidosis. Sarcoidosis. Can sometimes resemble TB also, but just read about it. Short description if you like. It's a granulomatous disease. Sarcoidosis, multi-system, mainly lung involvement, granulomatous disease. Right. Fine. Other causes? Drugs. Right. What drug? Methotrexate, good. Amiodarone. What do we give amiodarone for? Long-term amiodarone? For arrhythmia. Sometimes people give it for AF and things like that, long-term. Ni hamare kag? Can granuloma, TB වල any granuloma වගේ ඒ වගේ එනවා granulomatous changes ළඟ. It's not infective, it's again sort of a connective tissue වගේ තමයි. Don't worry about it too much. Okay. Anything else? Yeah. This is another culprit. Nitrofurantoin. Right. So nitrofurantoin is another culprit for interstitial lung disease. How long? He has been on nitrofurantoin for many years for UTI prophylaxis. Right, so that's a famous culprit. MCQ whatever you can get asked about it. So nitrofurantoin, long-term nitrofurantoin can cause interstitial lung disease. It's not very often that you see a case of it, but this is probably that, most likely. Did we find any other thing in the history to suggest a secondary cause for the interstitial lung, like joint pains, autoimmune things? You said that there were no exposures, but nothing. Okay. Pari. Smoking can cause ILD, right? There is a special entity called smoking related ILDs. So just know that there is something like that also. It causes something called combined fibrosis emphysema. Dekam eno. Emphysema, fibrosis. It can coexist. Smoking. Right. Another thing I would like to mention here is there are some ILD mimickers that present like ILDs. Just have a word or two about those. Those are these chronic pulmonary infections. Can you give me a very famous example? Sometimes that also presents with progressive shortness of breath and cough for months. But it's actually a chronic infection. This is a mimicker of an interstitial lung disease. The famous fellow is what? Pneumocystis. Pneumocystis. Right? Pneumocystis gyrovasi, which you get in HIV. So these are mimickers of ILD, chronic infection related ones. Mimickers, huh? Right. TB is also one of them sometimes, especially the disseminated form. It causes small deposits in the lungs. What you have seen miliary TB? That also is like a ILD, it's like Amatanama deposits. Right? And also these small deposits can occur in malignancies also sometimes. Secondary deposits. So be careful sometimes because you might miss them and go behind the interest. So infection, chronic infection. Now we saw a patient. Neither. Are we calling discuss of patient? Progressive shortness of breath. Where is that got? No. Shortness of breath and but had a probably infection going on. Maybe you think it is ILD but he had infection going on. So again that's a mimicker, you sometimes get misled. Hurry. Okay. So in this patient it is most likely that this is the culprit for the possible interstitial lung disease. Okay? Right. But the class today is not on nitrofurantoin induced interstitial lung disease. Right? It is the diagnostic process. Right? At the exam, same question. If you say COPD, why you think COPD, what is against COPD, and they will extract the answer out of you if you start off by saying COPD or something like that. Right? So what I wanted is interstitial lung disease at the top. And if you say directly without without knowing the case before and also at the exam this is probably nitrofurantoin induced interstitial lung disease, then you get a distinction. Right? Because we don't generally expect medical students to tell that as the first differential diagnosis for this sort of case. Right? So if you manage to tell that, you will get a distinction. If you don't mess the rest of it up, of course. But generally, we will have a very high regard of you. And the fact that you actually said this before this, that's why I asked him whether I looked at the ticket before. If you say this before this, then the examiner automatically knows that you know that nitrofurantoin can cause interstitial lung disease. It's implied because you have actually mentioned that in the at the start. Right? So that again, you get a good impression about the student. Hari? Okay, right. Now tell us what happened. You said you have been sent to the chest clinic and various things. So now we'll continue the story from there now. Hayin කියන්නේ වේගෙන් නෙවෙයි සද්ද වෙන.
He was referred to chest clinic, Morella, and diagnosed to have nitrofurantoin-induced lung fibrosis.
Okay.
12th of November 2018, he developed acute onset dry cough.
Right, wait. Now how do you think they would have diagnosed this in the chest clinic? The patient කියනද claim nitrofurantoin induced lung disease? ඒකයි මේක මෙතන කිව්වේ බිලියන්ස් එකක්. I'm just joking. Right. එතකොට interstitial lung disease කියලා diagnose කරන්නේ නැත්තේ කොහොමද? How would they have? What are the tests that they might have done? We have discussed this before also. I told you that there are 3 levels of investigating a patient with interstitial lung disease. What are they? First is to establish a physiological diagnosis of interstitial lung disease. Physiological diagnosis. Now the difference with the class that we had in pathology lecture and here is that there is a patient in the ward. So after this class all of you are supposed to go and see this patient, right, and learn from the patient. Kaddawan discharge kala the patient. Hey discharge. Then gihilla. Right. Sorry. How many of you saw this patient? None of. Very good. Ekek balloon. Right. So what are the physiological diagnosis? How do you establish a physiological diagnosis of ILD? Dumindo, do you remember how to do that? You have to demonstrate a restrictive pattern of lung function tests. So what is this restrictive pattern that we are referring to? FV1, FVC both will be low, but the ratio might be normal or sometimes high. Okay. So that's very common, and you can also generate those curves. This patient will be coming back for something again. Just so you might see the curves, flow volume loops, right? They also the report you can do that also, and that is generally අර මෙහෙම එකක් තියෙන flow volume loop කියලා එකක් තියෙන so ඒවා not important for undergraduates. Flow volume loop that also gives you an idea, right? Then there is something else that you have to prove if it's an interstitial lung disease. What is that? Apart from a restrictive pattern, the restrictive pattern can also occur with diaphragmatic paralysis also. So how do you prove it's really in the lung? Yes, you can measure the diffusion capacity across the alveolar capillary membrane, right? And that you have two measurements that we take, DLCO and KCO. Of this, the better one is the KCO because it is adjusted to alveolar volume. Right? So it's adjusted to alveolar volume. That's DLCO bedima alveolar volume samai KCO කියන්නේ. So that gives you an idea of the ability of the gas to diffuse across the alveolar capillary membrane, which is definitely impaired in patients with interstitial lung disease. Because the alveolar capillary membrane gets very thick and gases cannot diffuse across it. Right? Harida? Okay. Fine. So that's how you reach a physiological diagnosis. What do you do next? Second thing, then you do the radiological assessment, and of that the best modality would be to do something called a high resolution CT scan of the chest, HRCT. HRCT, high resolution CT of the chest. Okay. Third level is to get a pathological diagnosis, which is considered to be the definitive diagnosis. But if you see fibrosis and things on a lung biopsy, that is supposed to be the definitive diagnosis. And there are various types of interstitial lung disease also, which you can differentiate. But that's not important at undergraduate level. There are various types of interstitial lung disease, about 25 types of interstitial lung, not important at all for you. Don't worry. You might have heard of one, UIP, NSIP, there are various types, don't worry about them, nobody is going to ask you, right? So, biopsy, lung biopsy, right? So, sometimes you can get away with just the restrictive pattern, KCO, DLCO plus the CT, but in some cases we are not very sure, we would do biopsy. And biopsies can be done through the bronchoscope or through the axilla approach for open lung biopsy. So anyway you can do. Generally, if the lesion disease is small, if the CT shows disease in the central areas, you can go through the bronchoscope. If the disease is more peripheral, then obviously you would have to go through the chest wall and take a lateral approach biopsy. So this patient, did he have a lung biopsy? No, but the other tests were probably done. Okay. Right, then what happened to him? And also, once you establish a diagnosis of interstitial lung disease, you might like to send an autoimmune panel, right? Again, on your differential diagnosis, you might send an autoimmune panel like ANA or rheumatoid factor, those sort of investigations you might decide to do. But that's on your clinical judgment, right? Nika hamoge bawa karanne. Clinical judgment එක අනුව you will decide. Okay. Right. So then what happened to him?
On 12th of November 2018, he developed acute onset dry cough without diurnal variation. He does not complain of hemoptysis.
Right.
16th of November 2018, that episode of acute onset shortness of breath was developed while on dialysis, and he was immediately sent to NHS for further management.
So when was his dialysis started?
23rd of March 2018.
So I think that also, if you had mentioned here, CKD 15 years on renal replacement therapy with dialysis commenced in March
23rd of March
2018. එහෙමත් කියන්න. Otherwise this dialysis ගාව එකකට පොල්ලෙන් ගැහුවා වගේ dialysis කිව්ව ගම then you are a bit suddenly stunned. So I developed shortness of breath during dialysis. Now do you think that is the interstitial lung disease or could it be something else? That could be something else which we don't want to discuss now, but that could be something else that might not be the interstitial lung disease. During dialysis, shortness of breath can occur due to various odd reasons, right? So you need to take that separate. Okay. Right. Now what we are burning to find out is what examination. So we have done the history analysis to a certain extent. We have gone through the history. We have discussed. We didn't go to the Yatahariya. We didn't talk about hypertension, diabetes or anything like that, because my focus today is on this, the shortness of breath, right? So we have not Roshan. Nitimatay හොඳට. That is Sinduge kidna. So this. So now what we are focusing on, so we are mainly focusing on the shortness of breath. Other ones, there are problems, there are a lot of problems in this patient, but we are just focusing on this. Actually this sort of case is too difficult for you, but definitely I would give this for a postgraduate, no doubt, right? These are Dada's MD long case, but this part I wanted to highlight for an undergraduate. If you put all of these problems together, it becomes very, very complicated because you can get asked about anything, right? Diabetes, hypertension, CKD, ILD, so it's a very complicated business. Okay, right. So what happened now? So now what we are going to do is we are going to go into the examination to see whether our findings are consistent with our diagnosis. So respiratory, general examination. Not pale.
Not pale, no ankle edema, and why he has gynecomastia. On cardiovascular, on respiratory system examination.
Clubbing? No clubbing. Why clubbing? Because interstitial lung disease is associated with clubbing. Not all types, but most types. Right. So if you had auscultated this patient, he has this typical fine basal crackles, right? Of course there will be other patients who come with interstitial lung disease, but actually එක පැත්තක චුට්ටක් වැඩි. I thought it was more prominent on the left side, but bilateral තියෙනවා, right? Bilateral fine in-inspect typical crackles you get. These are also called velcro crackles. Velcro දන්නවනේ bag වල එහෙම seal කරන bag එක ඉස්කෝලේ bag වල එහෙම තියෙන්නේ velcro, right? So it sounds like you are just stripping two velcro strips apart. So that's a typical sound. And there are of crepitation. These are called showers of crepitation. You can get whole lot of crepitations. Right. So a physical examination on a respiratory system on a patient with interstitial lung disease would reveal clubbing and inspiratory firecrackers. Other problems are probably related to his background history. Right. Is there any specific treatment for this condition? Nitrofurantoin induced interstitial lung disease. No specific treatment apart from stopping the drug. Okay. Did he have a eosinophilia danne neda? Hari. Right, so that's it for this patient. Right, so now you get an understanding of shortness of breath. Now we have discussed two cases of shortness of breath which are slightly completely different from each other. Right. So because we are doing these together, you will appreciate the differences and how you analyze it and approach it. Right. And this argument for and against argument table is very important. So when you come with a differential diagnosis list, you should be able to discuss why did you say for, why, what are the features against, and you have to prioritize your list based on that. So ILD comes at the top because there are a lot of againsts for the other ones, right? Okay. Then we discussed about the causes of interstitial lung disease, and in this patient probably it's linked to nitrofurantoin use, and then investigation that you would do to establish a diagnosis of interstitial lung disease. Right. Any questions? Yeah, depends on. Here I don't think you need to do a lot of exclusion, but generally you have described it generally well. Somehow you need to, will come across cases like that. I'll tell you examples when you come across it. Yeah. That boy lost his set is missing. What is his name? Right. Where is he? Nobody knows. Probably. He has been present all these days in the morning, except for one day. Hari. Nobody. He has not said. Nobody. Okay, right. So that's it. So what do you have to do now? Unfortunately, I don't have enough time to discuss endocarditis, but that's okay. We can discuss it later. This one I thought was more important because fresh case, important to discuss this case. I thought the patient would have been still in the ward, but sorry, Tama. Right. Okay, so female ward. What were you doing in the morning? Somebody did a round. Shamsar did a round, and then Bhatia I saw was teaching something. What are you doing?
3 cases discussed.
Right. Good. What are the cases that you discussed? Where is the Cushing's patient? Cushing's, confirm Cushing. When is the IPSS? Today. Patient is there? Yeah. So downstairs I did 4 cases. All of you, one is of course is endocarditis one, but there is a nice patient with a endocrine problem. Have you seen that patient? Female ward people, or everybody has to see because that's not something that you see every day, right? So you have to, and the people who are in the male ward can teach the other people. So that's one thing that you have to see. And the other case I discussed, just discuss amongst yourselves. And similarly, the female ward හිටපු patients also you discuss. So how many have seen this Cushing's patient? Only female ward people. Go just wait. Hold up in a patient. IPSS එකක්. හා සෙවන් ගෙන් ගහන්නකො. Sean, was there a Cushing's patient? Cushing. Where is the patient? patient යවලද? මේ වෙලාවට නම් DSA කරන්නේ නැහැ. 18. This lady. අද උදේ පරීක්ෂණය කළා නේද? මොකක්ද ඇඟට තිබ්බ අමාරු මොලේ?
සීනි මට්ටම කන්ට්‍රෝල් නැතුව අවුරුදු 10ක විතර මොකද
තියෙනවා.
ඊට පස්සේ ඇඟ රිදීම එහෙම තමයි ආවේ.
බඩ එහෙම ලොකු වෙලා මූණ ඉදිමිලා වගේ. බඩ පොඩ
බඩ ලොකු වුණා. කොහොම පිටිමන ගතිය ආවා.
මූණ ඉදිමිලා නේ. හරි. Not a full blown typical here means she on treatment.
Yeah.
What is she getting? Ketoconazole. Pitrosine, so I'm probably sure where it's coming from exactly. MRI shows a tumor. Pituitary adenoma. Right. Right, so that patient is not a typical spot diagnosis එකක් නෙවෙයි. He probably is on treatment, so that's why I want to check before I took you there. Right. We'll discuss about Cushing's on some other day, especially we are talking about diabetes and poorly controlled diabetes and obesity. Keep that history, but just go and talk to the patient and see. But she doesn't have the typical full-blown textbook appearance, right? But some of the history might be a bit interesting, but remind me to do that. So see those patients and then you can come and watch carols if you like. Hari. Any problems? This boy is not coming, no? I'll have to catch the bell.
So what's the difference between interstitial analysis and fibrosis?
Lung fibrosis generally refers to a more sort of focal area of fibrosis. Now interstitial lung disease, there are many other similar terms. So interstitial lung disease, diffuse parenchymal lung disease, fibrosing alveolitis generally refer to the same condition. Fibrosing alveolitis is rather old term. So means sometimes you might find consultants using the word fibrosing alveolitis. That was used a long time ago, but it's not it's no longer used. So now we use either interstitial lung disease or some you can call it diffuse parenchymal lung disease, DPL. Yeah, fibrosis. If you say lung fibrosis, you are correct. All this is lung fibrosis. But generally, when you say lung fibrosis, it refers to sort of a local area, a focal point. Hari, so everybody is happy. No Wali, no problems, no issues. Right. So next week we'll start doing short cases because this week is absolutely out. Next week is okay. So our pahakata kadanna. Hari devakko. I asked some people to put up some pictures, say WhatsApp group if possible. All of you first see that patient I am referring to downstairs. Now, first see that patient and then go and have your tea and whatever and come. But that's not a patient you see every day. It's a very typical spot diagnosis. හරි දැන් යන්න යන්න.
Sir, absent.
Yes.
It's a mic. Sir, mic.
දැන් කැරල් සර්විස් එකේ කොහොම රෙකෝඩ් වෙයි?
What a pan up
admin කරන්න ඕනද?